for us here in Nigeria is 12:30 p.m.
Oh. But your time here is given as 1 p.m. your lecture time, right?
1 p.m.
When we start here,
Okay,
sorry, please come ahead.
Are you saying that we are going to start in the next 15 minutes?
Yes, you're right.
Okay. All right. I'll be back in the next 15 minutes. Thank you.
Thank you.
Nalini, I just sent it to him, just in case.
I will call him up and I will just see whether
Yeah. I'm going to go get my coffee meanwhile. I don't know if you can see me or not.
I'm not able to see you. Could you please...
I just want to let you know that my other computer, can you see me now?
Yes. I can.
So my other computer is having some issues.
Okay.
So hopefully this won't zoom in and out, because I like my other part of my office to be seen, which is more professional, but this is whatever. At this point, I'm good to go. 7:46 right now. Okay, I'll be back with my coffee.
Sure, please.
Yeah, thanks. So my other computer is having some issues. So hopefully it's back. It's recording everything, because I like my other part of my office to be seen, which is more professional, but this is whatever. At this point, I'm good to go. 7:46 right now. Okay, I'll be back with my coffee.
Sure, please.
Yeah, thanks. So my other computer is having some issues. So hopefully back, it's recording everything, because I like my other part of my office to be seen, which is more professional, but this is whatever. At this point, I'm good to go. 7:46 right now. Okay, I'll be back with my coffee. Yeah, thanks. So my other computer is having some issues. So hopefully back, it's recording everything, but I like my other part of my office policy, which is more professional, but this is whatever.
You shared yesterday's PPTs to Heritage Foundation RTC with Gmail. I have to save in these. You shared yesterday's PPTs. No, sir. In case you want me to share the screen, I can. She also just Shanta, Dr. Shanta, just now said that she has made present PPT to send it to you. Yes. Shanta. Yes.
Dr. Gangadharan, good morning.
Yes, sir. Just now she sent it to you. She's on.
Dr. Gangadharan. Hello. Is Dr. Gangadharan on?
In next few minutes, he's going to join.
Your PPT will come, don't worry.
No, I'm going to I'll do it myself so I can move fast because I didn't want you to get overwhelmed with so many of them because I just wanted to add and information, but I'm just going to move faster. So don't worry. 15 minutes, you said. I will take probably 15 to 20 minutes at the most.
Try to do it in 15 minutes time because we have 5 speakers today.
Yeah. Okay.
Try your best. Try your best.
I'll try my best. Yeah.
Good evening to all of you. I hope you all enjoyed the few minutes of this exercise. I'm sorry for a minute. My apologies. Good morning, good afternoon, good evening. I find Dr. Shanta Balasamy alone is a morning time.
Yeah, I got up early to be here on time. I was told we are starting at 7:30.
I'm continuing. Yeah, Dr. We have Dr. Sangeeta Kaur from Malaysia at 8 o'clock in the evening. So the two extremes. And we have people from 2 o'clock, 1 o'clock, 2 o'clock from, Netherlands, 1 o'clock from Nigeria, 3 o'clock from Uganda. So I think good greetings to all of you. So
Thank you.
partners in our efforts. This is the last day of 6-hour webinars that we have been, I would use the word very happily conducting on 28th of July, 29th of July, 30th of July, 3rd of August, 4th of August, and today is the 6th of August. I must welcome Dr. Mangaleshwaran from the Bharatidasan University, Dr. Nalini, she is my wife's namesake, from the Pondicherry University, who is going to head today's moderating session. Dr. Lakshmi, Central University of Kerala. These are the two people whom I have very closely worked in the past 1.5 years of time. Dr. Paneer Sigamani from the Central University of Tamil Nadu, who made a presentation last night. Dr. Chanaveer from Central University of Karnataka, who made a presentation the day before yesterday. Dr. Chandramouli, who moderated the session 3 days ago from University of Mysore. Dr. Leena Ashok from Manipal Academy for Higher Education. Unfortunately, she's not been able to join us as regularly as she wanted to be. And finally, Dr. Raja Samuel, Principal of Madras School of Social Work, who moderated the session on the 28th. Welcome to all of you. Now, distinguished speakers, Dr. Sangeeta Kaur from Malaysia, Dr. Shanta Balasamy from US, Mr. Namara Arthur Arali from Uganda, Miss Patricia Uju Akbalekar from Nigeria, Mr. Alex Lemix from Netherlands. Yes, it's been tough to get all of them across to, to come for this program. We had to talk to them, speak to them, write to them, and get them together. I'm definitely welcoming them with all that, humility that they all accepted to be part of this, sharing event. And yes, Dr. Nalini, Professor and Head of the Department of Social Work from Pondicherry University, she has consented to moderate this today's session. Quite a challenge for her today because we also have a valedictory address by a very, very important person, Dr. James from International Institute of Population Studies, who's director. And probably I will introduce him. I will introduce him at the end of all the speakers when he comes for valedictory. And sure, I would request Dr. Nalini to stay calm, keep drinking some ice creams or eating some ice cream so that she's calm. And respected delegates from across the part of various countries, I just need to mention the populations are growing older, living longer, thanks to the improved healthcare, increased awareness about preventive healthcare that we saw a few minutes ago. Wonderful exercises being performed at Brazil. I picked it up when I went to Brazil. They showed this to me. They demonstrated this to me. So I picked up this video. I have many of them with me. I have many of them from many other countries. Increased longevity poses new challenges to the global communities in which policymakers, advocacy organizations, families, individuals cannot be mute spectators. I think we're all able to talk in this forum thanks to the virtual world that's come in due to pandemic that arose last year. We are forced to act. I think that's what we are doing now. There are international instruments such as the Moderate International Plan of Action, WHO's Decade of Aging, international advocacy bodies like IFA, Global Aging Network in USA, and many others who are very, very active to advocate the cause of elderly. I must mention, since Dr. Shanta is also coming from US has one of the largest, probably the world's largest ARP body, membership of 28 million. I have been to a lot of their programs. They've invited me to address in several countries. So I know them, quite actively. So I've been part of them for over 2 decades. Now, United Nations is also, we have been discussing a lot in the last few days about the open-ended, elder abuse. I think United Nations has been talking about it for 10 full years now. This will be the 11th year that they'll be hosting the open-ended working group in New York. Now, I think they're all talking about elder abuse and neglect. And the International Network of Prevention of Elder Abuse has been strongly advocating this cause, and I hope their efforts don't fail. Now, coming to the social work, International Federation of Social Workers is one such institutions that does espouse the cause of social work engaged in geriatric care, but I believe that they should spread across the world, and countries in the Asia Pacific, which are aging faster, should be very closely involved in their activities. Community and institutional care are 2 major options left to those who have no families, to rely on the absence of families, or if elderly choose to live alone independently. So therefore, the role of social workers become an important area. In many countries, social workers play a significant role, as was evident in the last 5 days presentations. It was a wonderful experience that we have had from 5 days of presentation, how social workers have been able to impact, particularly, when you are talking about disaster planning. I think yesterday, wonderful presentation was made by South Africa to say how wonderful, how they manage the disaster. Wonderful presentation made from the Greece. I think there are many countries that have done extensively work on disaster planning with respect to the pandemic of COVID-19. I think social workers' role has been well recognized in those areas, those countries. And I'm very proud of the fact that, among all the, developing nations, Government of India funds old age homes, senior citizens homes for engaging mandatorily a social worker in every old age home which has 25, residents, and they fund this program. I think we are trying to study how productive they are, how impactful they are, and I'm very sure in a lot of places they are playing very, very dominant role. We are very proud about the fact that social workers are becoming an important factor in old age homes, particularly in the non-profit sector area. Now, as far as the private sector is concerned, I think the reality is that its little orientation is very different from the non-profit sector. Therefore, the role for social worker would probably be felt by them over a period of time. Maybe they'll take some more time. We are very proud. We need a firm state of role. We want to firmly grout the role of social workers in caring for the older persons. I think this conference is 6 days webinar is attempting to do that. I must say that the universities, that I've already mentioned, I don't want to report, have been extremely gracious to agree to the proposal to have this 6 days webinar, and they are all very actively participating. And I'm grateful to them and I welcome all of them. We value everyone's time and efforts. Let me tell you, people have been coming on odd times. For a lot of people, evening time, 5:30 to 7:30 is not convenient. For example, Dr. Sangeeta. She's coming at 8 o'clock in the night. If she has to stay for 2 hours of program, it is 2 hours. So they are valuing their contribution and learning. And therefore, she agreed to come at whatever time that we requested her to come. I would like to definitely place our deep sense of gratitude to everyone, every participant who have taken efforts to come. For example, Philippines. Philippines have written to me saying particularly they want to be part of this program, that agree to be for the 6th program. They are also ahead of our timing. We would like to acknowledge such efforts from countries where people are coming. Now, what we need from you, only one small gift that we need as organizers of this conference, not only Heritage Foundation, all the universities. What do we need from them? Just be indulgent. A lot of you have been asking a lot of questions in the chat box. We have not been able to answer them because of the time. But let me assure you, we'll get back to you with all the answers over a period of time. It cannot be easy because all the speakers are also very busy people. They may not be able to answer the questions whenever we ask for it. But we'll try to consolidate and send them, and we'll put it up in the website or write to all of you the way that we would wish to do that. Now, before I really close, I definitely need to, seek a gift from all of you. A gift to be calm, be proactive in these programs. Please remain muted. Never unmute your mic unless we request you to do that. If you unmute the mic, we are going to be in a lot of trouble. We don't have time. Kindly acknowledge your appreciation using the reaction button, which some of you started doing. I think by the time you all learn how to use it, maybe 6 days get over. But I would like you to really look for those, reactions and respond to the speakers who have finished their talking. And some of you can, we are not able to see you on screen because of the number, size, sheer size. Use chat box to make comments about the talk and your questions to the speaker. Kindly do not refrain from using a chat box to promote yourself and your personal interests. This is not a forum for this. Plus, this also distracts people's attention when they're reading your chat. We don't want to know about your personal things. We can always have different forum for that. Feedback is an important instrument for us to plan our future programs. Well, some of them come in the last 15 minutes, half an hour to give a feedback on the program because of certain reasons. We would really value each of those feedback. That some of you are reading the Facebook would have seen that in the last 4 days of time, I've been putting the feedback, some feedback that we get from the speaker, from the participants. Please pay some time. Today's feedback form will take 1 minute extra. We are asking for very specific questions regarding timing and other things. Please be a little patient today because we have 6 speakers, including the keynote speaker. And with that, I think those of you have been requesting for PPTs. Now, I requested Mr. Prabhakar, who's the person who's managing the show behind, to put up all that YouTube links today in the chat box. Please copy them, use it, because all the 5 days, including today, YouTube will be available to you. Kindly copy them and use it so you don't have to write to us asking for a PPT because they're all available to you. With this, I would request Dr. Nalini to take over. Dr. Nalini, I come in few minutes before Dr. Dr. James come in. I need to have a personal word of appreciation for him, acknowledge to come, and thereafter you play the role of closing the ceremony. And I've also requested all the the university representatives to be there today. If they are there, I would like to now and then keep their face on spot. If you're able to see them, that is all the small gratitude that I would like to express. With this, I request Dr. Nalin to take over. Thank you very much once again.
Thank you, sir. First of all, before I start, I welcome you, Dr. Gangadharan, who is the example of happy and successful aging, for this wonderful conference that you have organized. And a very cheerful good evening, good morning, good afternoon to all the experts, the distinguished guests and delegates and participants from Pondicherry, India. And it gives me immense pleasure to welcome you all for this last day of the international webinar on social work profession in geriatric care, current roles, challenges and emerging trends. We have had wonderful 5-day sessions, very, very practical and very thought-provoking. I'm sure you have gained a lot of, whoever has attended all the 5 of them, you have really gained a lot like what we have done. But today being the last day of this 6-day webinar with 6 very eminent speakers, I'm as eager as you are to listen to their experiences and knowledge. So without wasting any time, I'm now inviting the first speaker, Dr. Sangeeta Kaur from Malaysia. She has a psychology UG degree, a graduate certificate in anthropology and sociology, and a PhD in medicine. So wow, what a combination. Her goals are to ensure that minority and vulnerable groups are empowered and motivated to sustain self-care and self-resilience, to prevent or manage physical and mental health diseases. Most of Dr. Sangeeta's academic and current interest revolves around gathering evidence and ensuring that respective stakeholders remain informed of the findings and, when required, deploy strategic direction by enforcing efficiency and sustainability. So Dr. Sangeeta is today going to speak on evidence-based research to improve quality of care rendered to older persons. So now it's over to you, Dr. Sangeeta. Dr. Sangeeta?
Unmute.
Please unmute yourself.
Oh, sorry.
Unmute.
Apologies for that. Good day, everyone, since we're in a different time zone. Thank you for the kind introduction, and really grateful to Heritage Foundation for this invitation. It has really been very interesting 5 days. Let me just explain a little bit. The title, I think, might have got mixed up a little bit. I'm just giving an overview of Malaysian experience on social work profession in geriatric care. So I hope that is productive for you, as what the last 5 days has been as well. So I'm just going to touch a little bit of where we are now in Malaysian context, and are we prepared, and where we are going, and what is the implication of social work in our context. Just let me give you a quick overview of our population. There are about 35 million of us, and our population is growing rapidly. Currently, it's about, for the elderly population, it's about 7 to 10%, but we will see this increase in a near future as well. And I think most of you may know the famous Prime Minister, one of the oldest person, leader in the world, and we were really quite eager to see him to take the leadership role again, twice in his lifetime. And this really showed a great impact on, if you have a better quality of life, you can be productive at any lifetime. So with him in the context, even though his second leadership was very short, but we managed to advocate a lot of issues on geriatric care during his timeline. And we are projecting, and we are estimating about 16% of our population are going to be elderly. And even though we have very good systems in place, but we are already seeing a heavy burden on our healthcare costs. I think this is similar things that is known at the global level as well. We have 14 states, and 11 of the states in 2018 had services for geriatric care, but now it has catch up with other states, other remaining states as well. But regardless, the resources are still very limited. One of the biggest challenges that we are facing, and Dr. Gangadharan just started off the talk about today, is also the abuse. And that's why we are also looking at the implication of legality, especially for the healthcare of seniors. The life expectancy rate, like everywhere else, has definitely improved. But within the South Asian region, the Malaysians are known for our obesity rate. So we have a very heavy burden of comorbidities, which are actually coming at a very alarming early age in their mid-30s, and they have to live with it in their retirement age as well. So that is a big, huge burden on the healthcare costs that I mentioned earlier. But at the same time, we are also looking at the productive members of the society, the parents who are now taking care of their own children and end up taking care of their parents as well. So the household burden of care has definitely increased over the last 10 years. And, you know, this is really costly. It can be 3 times the minimum wage of a normal household. So that can be a problem within the Malaysian context. And it is not helping us because our retirement age has not improved over the last year, even though we had the most elderly person running the country, but the retirement age is still under debatable issues. We still can't be, addressing it with an earlier on aspect of how quality of life has improved over the years. So there are development needs that we have to take into consideration, and this is a cycle that we constantly debate about in our National Strategic Plan, and I'll do cover a little bit about this in my later slides as well. So we have a very active geriatric care association who really work very well with the social workers and other main stakeholders within the country context. And they have shown good evidence that, you know, if they do apply the policies and protocols within the clinical settings, it can improve institutional care. But nevertheless, we know that there needs to be a holistic approach. That's why they work with multiple stakeholders to improve this form of services as well. But having this, are we prepared for our elderly population? No, we are still not. We still need to do a lot, even though Malaysia is well known to sign off on every policy, every intervention, every operational guidelines, you name it, we have it. But there can be challenging aspects, especially when it comes to, the practicality or the reality at the operational level. We also are trying to advocate one of our islands, Penang Island, has a retirement home, and the government even in Penang has already indicate that they are concerned that it's nice to have retirement villages and all that, but we have to cater for all aspects of the population, not those who just can't afford it. So basically, where we, are our elderly population, encouraged with or optimistic about what we have achieved so far? Apparently not. We did contribute in a study that was conducted within 29 countries, and we ranked 4th, being very anxious about when we retire, because there are concerns about whether do we have enough to retire, and if we don't, are we going to be burdened on our family? So, but nevertheless, there's a lot of things being done out there by a lot of companies. As I mentioned earlier, we do have a pocket of intervention happening in all aspects of the community. And one of them is the corporate social responsibility area, where they actually provide grants, and they align these grants to the strategic plan, ensuring that we are catering or we are giving innovative ideas to promote such care and work with the relevant stakeholders as well. One of the university has also taken this role up very carefully and tried to map the services that are available. As you can see here, we have very good coverage of what we have and what we don't have within the public, civil society, and the private sectors. But nevertheless, this is only covering a very small population. So we do have to worry about what else is in place by the time we have 16% of the population comparing of all the elderlies. So we do look at independent living. We are trying to promote that as much as possible, but at the same time, we have residential and dependency care for our elderly as well. This is without any challenges like anyone else. We do have, to sustain such efforts or to maintain such efforts, and financial is always going to be a burden. But my main advocacy point is always the quality. Can we sustain the quality over time as well? So the Malaysian government has been very good. Like I said, we are very good at projecting and making sure that we are abiding by the international guidelines. So we've been working on things like this ever since 1940s, and we've been funneling the effort, moving towards elderly care as much as possible. But there's a lot of focus on nursing and aging homes, but when we talk about aging in place, we are still not there yet. We are not promoting a lot of independency of a healthy quality of life later on. But yes, we do have plans for retirement age, and we do have nice home care for elderly people, for those who can afford and for those who can't afford as well. So social workers actually play a huge role in our context because they have to continue to advocate for issues, and they have to look at where the evidence is, what the gaps are, since we have pocket of things happening in all aspects. It's very important for our social workers to maintain their skill and competency and keep up with what's happening so that they can advocate the right issues to the relevant stakeholders. Legal protection, like I mentioned earlier, is a big issue that we are concerned about. But with the pandemic over the last 2 years, the fraud issue, especially on the internet, it's becoming a big alarming issue for the elderly as well. And we really need to put something in place very urgently. There are some stakeholders working on this right now. And scams is something that we've been living for very long, but it has also escalated over the last 2 years. We continue I do consider myself as a social worker because I always advocate for the same thing. We continue to talk to the government that we need to start looking at things earlier on. Don't wait for people who retire. We need to start advocating and educating our community throughout their life changes so that they can be well prepared when they get to the certain age timeline. And we are promoting that they do use or consider transitional processes to theory of change, making sure that we start this process very early on because comorbidities are very, very high. And if we don't talk about it earlier on, it can be a problem at the later end of life. Here, I would like to talk a little bit about the societal and the cultural norms that we are heavily embedded with, and we are finding a lot of complication in these aspects as well. Since we have 3 main ethnic groups in the country, the Muslims, the Chinese, and the Indians, they all have their own cultural norms or societal norms or even their household norms that they have now become quite accustomed to. So these kind of things, sometimes, the children who are caring for the elderly, they think that the best thing to do for their parents is, tell them to relax, have a relaxed lifestyle. You don't need to go out. You just have to stay home, enjoy life in front of the TV. And this is becoming very evident these days. And most of my research is indicating that 60 to 70% of the elderly are actually spending their time in front of the TV. So sedentary lifestyle is a huge problem. With COVID-19, and most of the speakers have touched on this as well, social isolation is a big, big issue, but this isn't an issue just over the last 2 years. It has been an issue over the last 10 years, and 40 and 50% of the elderly are definitely impacted with issues around social isolation. And now in the last 5 years or so, we are starting to see these granny dumping society problems that we are seeing, where people, especially families from the low economic group, they do not have enough support. They can't sustain a quality of life for the parents. They're leaving them in the hospitals or they're leaving them on the roadsides. So there are some of our experts trying to put together strategies on how do we educate our population a little bit better so that they know what kind of services are available out there. So in conclusion, what I would like to emphasize is that, and I always advocate this with the agencies, the relevant agencies, the fact that the social workers play a very important role, start to talk about issues that we need to work with our community and our household as whole. We don't just target a certain age line, but we need to talk about aging throughout the whole process. And therefore, I also advocate that the social workers need to maintain their skill and and competencies throughout their lifetime because they have a lot of experience, but at times they can get burned out with, the circumstances that they're facing. And plus we need more trained people out there because our ratio is far more less than compared to anything else a developing country has to offer. M&A framework as a public health specialist, I always emphasize on this. I make sure that, we advocate for better quality and improvement of services. Unfortunately, right now in Malaysian context, we are actually parked on anything to do with the elderly strategy or plans. We are parked under Ministry of Women, Family and Community Development, Social Welfare Department. So you can see that's a very mouthful already, which means they are doing a lot. And they definitely cannot cope with the ever-growing needs of a specific population. So that's why we are advocating for the elderly people to be parked under a strategic ministry or stakeholders who can really pay attention to some of the issues. So education is key, and I think this is the bigger thing that the social workers can also help us advocate and improve volunteerism between the community as well. And I always request the same from our academics to do the same thing with their students, to talk a little bit more about this and to ensure that when they do volunteer, they're actually learning as well. So this is a positive outcome that we all hope for. And, definitely we need to continue to advocate for positive active aging so that, we want people to be independent as much as possible. To do that, we need to start early. Okay, and here you can see we have a very nice strategy on our objectives in place, but like I keep saying, we need to look at it on a very lifelong learnings, and also again emphasizing the facts that we do have to have better monitoring and evaluation processes in place. That's all from me for now. Thank you for listening. I will take questions when you're ready to do so.
Thank you very much, Dr. Sangeeta Singh. I mean, you're bang on target as far as the time is concerned, and a very lovely presentation where you've highlighted. I'm very happy to know that, you have such a 23, I mean, you have a 93-year young leader, but still there's lots left to be done for the elderly. So we'll take questions later. Now I'll invite the next speaker, Mr. Namara Atur Arali, and he has a wonderful profile, but unfortunately we have just cut it short. We have picked out the most important ones for him, and he's really doing a lot of work in Uganda. He's a social gerontologist. He has a master's degree in gerontology from Southampton University in UK. And he's a project leader and community liaison officer, NCDS, Uganda. He's a member, Uganda National Council for Older Persons. He's chairperson, Research and Documentation Committee, National Council for Older Persons. Member, NCD Technical Working Group. And he's worked as Minister for Foreign Affairs and Information Minister in Turo Kingdom in Western Uganda. And he's part of the NTEC sub-district COVID-19 task force, where together with his team, they managed to reach out to over 2,000 older persons with relief items. And he's also with the NCD Technical Working Group, Uganda Ministry of Health, member, TASO NTB Center, Advisory Committee member, Uganda Commonwealth Scholarships and FA Associations. He has several awards to his credit, and I'll read out the most important ones because there's a big list. Jack Waters Memorial Award 2016 for strengthening responsiveness to older persons, issues and concerns in Uganda using an innovative approach. Good Leadership Award by Uganda Red Cross Society 2002 to 2006. And there's a lot of other things. I'm sorry, Mr. Namara, because we are more eager to listen to you. So we are just coming over to you straight away. And today he'll be, Mr. Namara is going to speak on Uganda National Council for, Community Services by Social Workers in Uganda. So over to you, Mr. Namara Atur Arali.
Thank you very much, Professor, for that elaborate introduction. Thank you very much, the organizers, for inviting me to share our story. As you rightly saw, I'm a gerontologist. We have very few gerontologists in Uganda because we don't have any institution that can take us through that course. we are trying to advocate for it. Yeah, my presentation outline is as follows. I will give just a brief introduction because of time about Uganda, about Health Nest Uganda. Then I'll talk about briefly the way of working, the way we work here in the community. I will describe briefly also our areas of focus. And then I will talk about the role of social workers in our work. I will enumerate our achievements and maybe share the next steps that we have. So like many other countries, Uganda is also aging. And as our presenters yesterday said, this shouldn't be a worry, but we should be celebrating for living more. And we have had numbers multiplying in Uganda. However, unlike in developed countries, in most developing countries and especially Uganda, we are increasing numbers, but not with riches, but with poverty, moving with it. So we have an aging population, but also poverty is high amongst that population. Most of older persons are living with the 1 or 2 NCDs, and unfortunately 48% of our older persons in Uganda have no formal education, and especially women, because of our cultural practices. Though in Uganda, we have very, very, very good policies regarding older persons. I think we are the first country, I think, in Africa, which has members of parliament representing older persons and elected directly by older persons themselves. We have a national council for older persons in Uganda with representatives from both from the village up to the national level. And we have a national policy for older persons. However, those policies, as good as they have not translated into better systems. Like, for example, we don't have any well-developed geriatric care in Uganda. And our health system is not very responsive to the needs of older persons. I founded Health Nest Uganda in 2007 myself, and the idea of starting Health Nest Uganda, I got it from a clinic where I was working as a health educator, where we were conducting research and excluding older persons. And I remember an older person coming to me and asking why they were segregated, why were they not included in research? Because we were including people of 18 to 49 years. So we're excluding the older persons. That one challenged me. And I realized that even in the clinic, we had many older persons actually that were accompanying children for care, but no one was caring for them. So that's what motivated me to start Health Nest Uganda. And it has grown over the years. Now it's a network, a member of Help Age International, and it has had awards being accorded to it because of our way of working. What makes us unique is that we have a special way of working. We use a strength-based approach called community life competence that promotes active involvement in decision-making by older persons. It promotes older persons to be active participants rather than being passive carers, passive recipients of care. In the photo that is accompanying this lady, you see we organized a meeting that had older persons, the health workers, and the social workers sitting together on a round table to discuss what concerned older persons, of course, with their active involvement. We promote alliances between key stakeholders in Uganda, but with older persons taking the lead, because we believe that whatever you do without them is not for them. Our areas of focus are mainly 5. One is health promotion among older persons, sanitation and hygiene, promotion of physical activities, livelihood for older persons, and then we look at nutrition. Those are our areas of focus. Under health promotion, we aim at connecting the informal and formal healthcare workers. We use retired health workers in the communities to screen their fellow older persons for NCDs, conduct health education within the communities, and make referrals. We had to retrain some of the retired health workers to orient them into NCDs. And they are doing a very good work because we already established a referral pathway between the community and the hospitals, a number of hospitals in Entebbe. What we did, for example, in Entebbe Hospital, we had a volunteer put at outpatient department where everybody who is screened from the community is referred and received at the outpatient department by the social worker, volunteer at the outpatient department, who then helps older persons through the pathway of care within the hospital. Originally, older persons would come to the hospital, disappear from the crowd, and they don't get assistance. They end up going back without getting care. And that one had chased away from older persons for attending services in the hospitals. And actually, the majority had embarked on using local herbs as an alternative medicine. But because of this collaboration between the informal and formal health workers and the social workers being a driving force, we are seeing an increasing number of older persons comfortable to come and seek healthcare services from the hospital. And then we also do, under health promotion, we do HIV testing and counseling, and that one is driven also still by social workers. We do integrated home visits, and this is done by the nurses and the counselors together. And then the referrals are done by the community volunteers that we have. During COVID, lockdown and the pandemic effects, we did a lot of work as they introduced us. We have offered counseling services to older persons to make them understand, and this is done by social workers. We have formed a WhatsApp group for older persons to disseminate factual information, because there was a lot of rumors and misinformation at the outbreak of COVID-19. And our social workers make weekly calls to older persons who will not be living alone in order to manage that loneliness. And then we also offer food support, soap, face masks to all vulnerable older persons. In the picture corresponding this slide is me handing over a package to an older persons. And then because most of the health centers, more especially in Entebbe Hospital, was locked from the public and made a screening center for COVID, most of the older persons who were accessing NCD's services were blocked. So we have worked with social workers to ensure that drugs are delivered to these older persons within their homes. The other thing that the area of focus is sanitation and hygiene. Here we focus on redesigning pit latrines to make them more user-friendly for older persons. During our work, we realized that some older persons actually were fearing to eat food because they would fear to use pit latrines because of the pain of squatting they would pass through. So together with the health workers and social workers, we have embarked on redesigning pit latrines. We just cut the corner of the ceramic seat, and then an older person is able to sit on it, and the fecal matter goes direct into the pit rather than having a squat on that pit. We are doing also rubbish management because we believe that health is made at home and repaired in the hospital. So we do a lot of awareness about rubbish management around homes. And then we also create awareness about the importance of sanitation and hygiene within homes. We also conduct physical activities with older persons, at least in a week. We want someone, at least an older person, to have conducted at least 150 minutes of moderate exercise that are age friendly. These exercises are done as individuals, and some are done in groups. As one of our predecessors said, that independence, at least you promote independence with sufficient support. So we support them to have activities like exercises together in groups, and some as individuals. We also look at livelihood, and here we promote income generating activities. We helped them to get briquettes, making charcoal for fuel. This one has 3 benefits. One is that it is an income generating activity. 2, it promotes also health aging, because now they avoid using firewood that gets a lot of smoke to them that impacts on their health. And then they use these smokeless briquettes. And then it is also environmental friendly. Fewer trees are cut because now they are using briquettes made from rubbish. And then we have helped them form circles, saving schemes, because here banks don't lend older persons because they are termed as risky borrowers. So they have a slogan that if they cannot lend us, then let us lend ourselves. So they have formed circles, which is benefiting them. Nutrition, we are promoting backyard gardening for most of older persons. Actually, during the COVID pandemic, what we have seen has been food insecurity. So most of our older persons have been trained to do backyard gardening, so that even if there is a lockdown, they can have their food within their environments. So this one, at least we have every homestead having some small garden, at least behind the house, to make sure that it can also help in case of scarcity. The other thing that we have done is we have constructed a wisdom center that actually is going to help us manage boredom among older persons, because the older persons will be congregating within that wisdom center to share knowledge, to share information, and also to remind themselves of the past. It's going to be an intergenerational center whereby we are going also to have younger people and older people sitting together to tell stories of the past and maybe conflict resolution, but also to have younger people teach older persons modern technology with the slogan of leaving no one behind. So this Wisdom Center is already up, and it's going to offer also opportunities for research among our students. And also we shall have a rehabilitation center. We shall be in the future introducing a gym at the center whereby older persons can come and continue with their physical activities in order to age gracefully. So briefly, the roles of social workers, I have mentioned them before, but specifically within our perspective, social workers have acted as a bridge between older persons and internal hospital healthcare services. Social workers are playing a key role in offering psychological, emotional, and social support, more especially to those diagnosed with the NCPs. Our social workers are ensuring that older persons receive the services they need within the hospital and actually in the community. Our social workers in our team are also advocating for the rights of older persons and ensure that their voices are heard. Our social workers conduct counseling sessions to orphans under the care of older persons and the older persons themselves. Here in Uganda, about 63% of orphans are under the care of older persons. So the social workers really are doing a great job. Social workers guide older persons on other non-medical interventions like exercises, nutritional counseling, and guiding them on appropriate income generating activities to contribute to successful aging. Achievement, I can say that we have created a dialogue between health workers and older persons. Now actually it has changed attitudes of both the health workers and the social workers and the older persons, because there's older persons used to fear the health workers, thinking that they are rude, they don't care about them. But also health workers used to look at older persons as a spent force and taking time. That one has been changed because of our dialogues and the meetings and working together. As I said before, we have also observed the increase of uptake of health care services by older persons within our municipality. A number of older persons have started backyard gardening because of our intervention. And Entebbe municipality is in the process of making laws that enable older persons access services without have to line up and waste a lot of time. And then access to toilet facilities has also improved because of our intervention of redesigning the pit latrines. Lastly, we are working with all stakeholders, including older persons and the National Council for Older Persons, Minister of Gender and Minister of Health, to align our health systems to the needs of older persons. That one is in high gear and meetings have started taking place. We want to promote a multidisciplinary public health approach because we have observed it during COVID and the HIV approaches that healthcare is beyond medical. It is a holistic, it needs a holistic approach that includes social workers. The other thing we would like to improve and which we are working on as a National Council on Health Nest Uganda is to improve measurement, monitoring, and research for geriatric care. There is a lot of information that we don't have in the country because of lack of research geared towards older persons. Then we are also advocating for a model of work to be upscaled in Uganda, because according to Uganda 2040 vision, healthcare is supposed to go back to the communities and target households and to promote preventive rather than curative care approaches. And the other thing that is also on our high agenda that will include social workers is to combat ageism in all sectors of our community, in all sectors of our government system. There is ageism and we are going to work together with social workers to improve that one. So thank you very much. Those are my contact details, and these are all the persons that we work with. Thank you very much for giving us this opportunity to share our story.
Thank you, Mr. Arali. That was a very nice presentation. And especially, I'd love to know more about your community life competence, where you're involving the elders in decision making, and the Wisdom Center. Both of them will look like very innovative ideas. So probably you'll have some questions. If time permits, we will take one or two questions on that and your presentation. Thank you. And now we move on to the next speaker, Mr. Albert Lemix. He is the CEO of Maria Wood with extensive experience in healthcare. He is based on a nursing background with numerous specializations in ICU, anesthesia, cardiac, neurosurgery, and traumatology. He worked previously also as a marketing, sales manager, IT, and as an account manager for one of the largest pension funds in Europe. He was also a trainer, coach at management schools in the Netherlands in business administration. Change management and healthcare finance was his key area, and he has a broad development in the areas of healthcare, management, IT, business administration, and marketing. He manages processes and people and does so from a result-oriented vision. His management philosophy is to support people and to design processes in a way that facilitates staff with results as a focus. So now it's over to Mr. Albert. Welcome, and we request you also to please stick to the timings. I also happen to see your YouTube on with regard to Maria Wood and how we are validating the elderly. It's very interesting. So now over to you, Mr. Albert.
Do you see my presentation on screen?
No, not yet.
Let's see.
Prabhakar, should you help him? Prabhakar, can you help him? In case.
So can you put my presentation
Yeah,
on?
yeah. Prabhakar, can you do that? Yeah, hold on.
It would be nice because
we can do that.
Okay, thank you very much. I will start talking. Perhaps you will see the presentation online. Thank you very much for your invitation.
Prabhakar, can I do that?
Yes, sir. Please, sir.
Okay.
Okay. Thank you very much for your invitation. I hope you will see my presentation on screen soon. First of all, I like to say that when I hear you talking about the elderly people and the problems and the challenges you see, it's very easy for me from the Netherlands and Europe to talk about the problems we have. But when I do see people around the world in Asia or in Africa, they sometimes tell me, well, I had your problems. So I think when you hear me telling about problems in Europe, I do really know that there are other problems in the rest of the world. You see my sheets. Perhaps you can make the screen a little bit larger, so we can all see the.
1 minute. Layout.
In the presentation mode.
Yeah. 1 minute.
Yes, thank you. Next sheet, please. Well, the current situation in the Netherlands, we have about 17 million people, and in about 10 years' time, the 35% of them will be older than 65 years. So we have a major problem on our hands. Next slide, please. We have a fully privatized organization in aged care. Everything is taken care for. Next slide. Nursing homes are part of the healthcare system. Healthcare and nursing homes did develop from each other. Nursing homes came out of the hospitals and were taken further. Next slide, please. So now we are in the middle of a transformation of where we see care homes taken away. And it's not payable anymore. We need too much care homes. There are too many elder people. So we have, the government has said, this can't be done like this. We have to do it in another way. And the other way is we have to keep the people at home. And only when the problems are so large, you can't stay at home, we have to make a different approach. Next slide, please. And that means that there's an extensive supply of home care and very much more things have to be done at home. And that's not easy. The next one, please. We have a very high quality of medical or nursing care. In Europe, around the world, we're known for our care. But I think, and we think, that care for the elderly is not medical care. But the last 25 years in Europe, elderly care was medical care. Next slide, please. So highly medicalized. You need a nurse, you need a general practitioner, you need a doctor, you need an education to come into the system where you're going to be held. And that doesn't work. Next slide, please. This is the last 10 years where you see, the next slide, please. The Netherlands having the highest costs over Europe, Canada, and the USA. Our neighbor is Sweden. We pay very much more, but the citizens of our countries don't live any longer than the other ones in the sheet. Next slide, please. And also here, next slide, you see that the Netherlands and Sweden are scoring very, very high. So there are simple reasons. I heard other people also saying 35% of the people above 65 years old. We can't continue building care homes, and have already the highest prices of Europe. So we are doing something wrong. Oh, but what are we doing wrong? Well, that's the question we have in Europe and in the Netherlands, the same as you do. Next slide, please. But this is what research shows, that 40% of people going to long-term care institutions do this because they fear, or their family fears, something is going wrong. That has not to be the case, but it's the idea of having problems. And often that has nothing to do with medication or medical things, but it has to do with social environment. And it has to do with how you feel. Are you happy? Do you have vulnerability? Are you safe? So we think we have to approach this case in a different way. Next slide, please. And then there is something different. When we see this picture and this slide, we almost immediately feel happy. A small child not knowing what to do, we help him when walking, and he has a diaper on. Next slide, please. And now we have a problem. Well, I think it's a way of thinking. Aging is like being a baby, a part of your life. And probably there will be medical problems, but being old is not being sick. So you have to take another approach. And that approach, next slide, please. It made the government say, well, I'm the co-founder of an idea, community care, bring the community back. And perhaps in your country, some of you do have a community, and be proud of it, because we have to build them back. We have lost the community, we have lost the social structure, and then there is a real problem. So social structure is the most important thing, I think, and a lot of people here think. The arrangements to keep people with dementia at home is only because we have also a very large population of people Alzheimer and dementia. So we said, let's start the experiment there. Next slide, please. It's called community care. I will show you the paradigms, the goals, and how we finance it. Next slide. It's not money, it's not medical. It's needs from persons, human, social, physical, in an individual context, but also, and very important, with a notice of meaning of life. What am I doing and why am I doing this? A very part of being old is being vulnerable and have trust and safety around you. When you don't trust, when you don't have safety and you are vulnerable, you're likely to call in the Netherlands a nurse or a doctor or your family. So we have to work on that. And you're a whole as a resident and you're part of the community. So next slide, please. We want to restore the role of the relatives and the network. And that's what other people also said. You have to start very early. When the problems are there, it's too late. You have to interact with the people and say, and ask them, when you are growing old, and in all of our countries, we are going older and older and older, what are you going to do? What are the things you and your family are going to take care of? And of course, when possible, we will help, but it's your own problem. And when your network disappears and you're getting older, well, if you're all on your own, then it's very hard to go to get your help. So we are going the other way in the social structure. Next slide, please. So the goals are promoting mutual support between residents and partners, and that's in the vicinity around a a care home or a nursing home, but you live in the environment, you live nearby, you live in the village, and together you try to work with your network. And when needed, there can be informal carers, and if extra needed, then there can be professional staff. And then there is a magic word, and the word I've chosen here is life coach. There is a social worker around you who is authorized to talk to the different systems of medical care, healthcare, general practitioner, social care, municipality. So you are serviced in a simple way that it's not your own problem, or it's not a problem of the children, of the caretaker. It's a problem you can address with your life coach. And if necessary, the life coach has the opportunity to ring the general practitioner, to ask for a nurse or for social work, but that's the coordination principle. And you're not alone. 35% of the country is older than 65. So why not care together and go to your neighbor and say, well, I have the same problem. And that means working together with the municipality, the health insurance, long-term care, etc., with one goal, but also with one financial system. Next slide, please. Because there are different financing sources all around, also in your countries, but that doesn't matter for the client. That doesn't matter for the citizen. That doesn't matter for the social care worker. He says, well, I don't have to know all your laws. I have a problem and I want to be helped. So the financing sources have agreed that the life coach can start actions and they will be paid for. And of course, you have to tell them why you do it and how you do it. And there is a budget, but the life coach has the meanings to help. And in the older system, you had to be paid by the minutes of care you did, because that was the process. It was a business model. And now we say, we are not going to pay in a business model for the minutes, we're going to pay for the whole group. Next slide, please. So we're financed on a population, it's supported by the government, budget, collective qualifications, no framework for outcome other than quality of life. And quality of life has also all kinds of different things. It's not only health and environment, I tell you, freedom, opportunity, living standard, peace, security, and the well-being. That is the outcome of the audit. And the budget, I already told you, for the whole population. Last sheets, I think, perhaps. Next sheet, please. So then you come in the system. In the system, we take care of you with the life coach, your requirement, wishes, opportunities, and that's a circle you all have in your own countries. Next slide, please. And what's very important, the life coach does ask you in the start of your program, which 3 things must be arranged so you can live independently for as long as possible. And nobody says, I need my medicines 3 times a day at 7 and 8 o'clock. Nobody says, I need to shower every day at 7 o'clock. They tell you, I have a problem with my husband. He's very aggressive and sometimes he tries to beat me up and I can't handle that. Or the problem is not me, but the problem is when my daughter is not available, I do have a problem. And when you don't address the things the people themselves know as their problems, you're not going to help them. But this is a very big change also in thinking in the way of doctors and nurses and social workers. So we've made it simple for them. Do the things you would do for your mother and your grandmother within the possibilities. Dream big, act small. Last sheet, please. What's the current situation? We have an integral budget and the pilot started in 2018. There's a very large research been done by the Dutch government which underpins the results. Since 2020, it's in the annual plans of the government and it will be implemented in law in 2023. There are plans for implementing the pilot in the Dutch province with the pilot size about 12,000 people. My last remarks would be simple answers to difficult questions work the best. We always think in try to make it better, but you can't cure being old. That's part of life. Do the simple things. Do simple things first. Sometimes it's very easy to help and you won't believe it. But what's difficult is prove things work not as easy because the medical model claims attention and results. We have always thought it's a medical problem, we need to help. And that's okay, but sometimes doing nothing could be best. I thank you very much for your attention.
Thank you very much, Mr. Albert. It was a very interesting presentation and it's new terminologies, especially the life coach and the term informal carers was very, I mean, that was an interesting new thing that I learned. And I'm really surprised, I'm wondering the way you have explained about your problem, the need for more and more institutional care that had to shrink finally, and that now we are looking for extensive supply of home care. All that I'm wondering is where is going the manpower come from for even the home care or attending to the needs of the elders, because that's kind of a problem very soon India will also face. We also having increasing number of institutions for the elderly. So I think we're all together we have to find a solution, and I'm sure Dr. Gangadharan will help us out in this process.
I will gladly answer your question when there's time available.
Yeah, there's a lot of questions. In fact, hopefully we'll get some time. Very, very interesting presentation. Thank you, Mr. Albert.
Okay.
And, now I'm very happy to invite Ms. Patricia Uju Agba Modi Kezu. I hope I pronounced your name correctly, Ms. Patricia. And Ms. Patricia is at the University of Nigeria, Zuka, as an academic staff at the Department of Social Work. She's currently pursuing PhD program in social work with specialty interest in social gerontology. She's an MSc in social work. Her primary research interests are in the area of social gerontology, gender studies, and public health. Uju's publications include articles in the End of Life Plan, Age, Development Studies, maternal health issues, and COVID-19 and older adults. Today, she's going to speak on social work practice in Geriatric, innovative approach suited in Nigerian context. So it's over to you, Ms. Patricia.
Okay, thank you so very much, Nalini. I hope I pronounced your name well. Greetings to you all from Nigeria. I am Patricia, like she introduced me. Let me not mention the surname before you start having hiccups in grabbing that. Okay, so thank you, Ganga, for putting up this meeting. I will go straight to the business of the day. I am a social worker. I'm a social work educator, and with specialty in gerontology, and I've done a whole lot of research regarding caregiving to older adults and yes, regarding caregiving to older adults and social work perception and care to older adults. Okay. Dr. Ganga, I don't know, I'm having technical issues here. Can you help me share the screen?
It is fine. It is fine. We are able to see your practice.
Okay, can you see my screen?
Yeah, we are. Are you all able to see? Dr. Nalini, are you able to see?
Yes, we can. Probably she can go screens,
Don't
full.
worry.
Okay.
Don't worry. If she struggles, don't worry.
Yes, it's fine,
Yeah.
fine.
Okay. So I will be telling us social work practice in geriatric care in Nigeria, and I will be sharing the innovative approaches suited and observed in Nigerian context. In the outline here, you can all see, can you see that? You can see the content of what we are going to discuss. We are going to talk about social work profession in geriatric care in Nigeria, and we are going to look at the challenges facing social workers, the innovative approaches we've adopted here, the anticipated trends, the possible challenges to encounter, and the roadmap to better practice. Yes, social work practice in geriatric care in Africa and in Nigeria, to be specific, is relatively young because we are still grappling with bringing on our indigenized content and the peculiarities within our context. So we are still modeling what we were given from from our colonialists. I don't like to use that word, but I have to, where we adopted their social work model of practicing. So, social work in Nigeria still exists as a university course. It is not yet a profession. So it's still a course students enroll in the universities of learning here and read for 4 years, graduate, then they go into the society to practice in their different areas of choice. So the geriatric care in Nigeria, to be specific, is traditionally provided by filial networks such as the families and the relatives of older adults. This is the most common option we adopt here, given our peculiar cultural practices and beliefs. So what are the challenges facing social workers in geriatric care in Nigeria? The first challenge is inadequate trained geriatric social workers and our poor visibility. The few trained ones, we are not visible in the society. And given the issues like such as social work in Nigeria being new, we are still grappling with adapting it fully. And again, given our cultural peculiarities, which usually preach filial care to older adults. Hello, can you all hear me? Because my network is
Yes, we can
somehow
hear you.
misbehaving.
Patricia, please go ahead.
Okay, so I'm still talking about the inadequate trained geriatric social workers we have here. So, and the issue is because of the fact that geriatric services are often provided by religious institutions and private individuals. We call them non-governmental organizations who set up homes to care for our aging persons. Then again, most of the staff working here in our care institutions are not trained social workers. These institutions, when they establish them, they will just hire anybody that is available, not minding their profession, give them what they call training, and they go into the field to begin to, provide services to the older adults. Some of these persons, they train them and send them to the homes of the older persons to provide care to them. And some of them, also like the religious organizations, house the older adults. And you can see them there, house them and provide care to them. Then another issue we have is lack of professionalization of social work. Yes, social work profession in Nigeria is not yet a profession. We are not yet recognized, we are not licensed, and that is really a big issue for us because, one, our social work profession, yes, is not really popular with our policymakers, so we are still finding a way and still struggling to be visible, to make our presence known. Then again, another challenge we have is our curriculum of education. Yes, I'm a social work educator. And if you look at our curriculum, you find out that social work in geriatric care as a course is being taken as an elective course, that is an optional course. So, and it's a problem because most students, when you tell them, when we advertise what we do and to stimulate their interest to come and learn our specialty, they will say, what will I gain by learning how to take care of the older adults? Will it give me money? These are the kind of feedback we get from our students. So we have advocacy is ongoing at our level here to make sure that, see how we can get the NUC, that is the registry institution, to help us to see how we can incorporate our course, which is social work in geriatric care, as a core course and not an elective, so that we mandate these young ones to come and learn social work in geriatric care. And the reason why we do that, why I'm making that advocacy with my colleagues here, is to make sure that in the near future, we'll have young persons who will take over us as gerontologists, as specialists, because if they don't show interest in being trained, we will continue to have large number of untrained persons providing geriatric care to our older adults. Then another issue we are having is that institutionalization of the older adult is not popular, both among the Nigerian policymakers and the general populace. Recently, I rounded off my PhD fieldwork, and it was situated on seeking the views of the older persons regarding residential care placement, that is placement in nursing homes. And we found out that majorly they preferred to age in their homes. They preferred filial care from their filial networks rather than being placed in an institution. So, and it's a major challenge because when we promote introduction of alternative care options, these individuals are older adults. Most of them tend to frown at it because, one, it is not traditionally recognized. And again, the policy document here, our social welfare policy, also is a big challenge to us because it de-emphasized institutionalization of older adults. In fact, it is a taboo when you look at our policy document. But there again, despite the fact that it is not emphasized mainly here in my country, organizations and religious institutions still see the need to put up these homes, and they go against the policy to have these homes. And there are a whole lot of implications of doing that. Now, what are the approaches what are the approaches we adopt here in Nigeria? Currently, I have said that there are institutions here that were set up by individuals, and what they do is train home-based caregivers. They hire anybody regardless of their qualification, give them training, and send them to the homes to provide care to these older adults. And the arrangement is that the family, that is the children or the relatives of the older persons, pay them. Then we have daycare centers owned and managed by religious organizations and individuals. And they provide daycare services whereby the older adults are taken to these institutions, and at some time, at a certain time within the day, the families will come and pick them and take them back home. Then we have residential care facilities, also referred to as old people's home here in my country, owned and managed by religious groups. What are the anticipated trends? There is a likelihood of abandonment of older adults with no care provision, leading to a high preference for institutional care options. Why did we anticipate this? Given the observable changes in family makeups, the issues, the structural changes affecting the family, the economic downturn in many countries in the world, you will agree with me that the care we provide to the older adults is diminishing, both in quality and in quantity. Because you find out that if you go to the rural area, this is one of the rural areas where me and my colleague went for field work. And we found out that a lot of the older adults are left without care to care for themselves. Some of them are barely managing to, take care of the activities of the daily living. And look at the young ones, their caregivers. We interviewed them about their views regarding providing care to the older adults, and they are saying that in the near future, given the demands, to meet the needs of the family and engage in meaningful labor, that they may likely abandon these older ones to go out to the urban area to take care of themselves. And that is why we had this, we anticipated this. And also from the field work I talked about, my PhD field work, we discovered that a significant proportion of the older adults are willing to be placed in the institution rather than being left alone with no caregiver. We also anticipated the likelihood of the growth of community-based care, where caregivers are paid to provide home-based care to the older persons, given the activities of the institutions that train and send some individuals to go and provide care to them. Lastly, we also anticipated an increase in the sensitization and awareness of residential care options by geriatric social workers. That is what we are doing. What are the possible challenges to encounter? There will be, we expect that there will be persistent misconception about residential care option, that is nursing home placement by the older adults, due to centuries of filial care. Filial care, as I have pointed out earlier, is traditionally recognized both in Africa and in Nigeria, and it is posing a big challenge. Funding. We also found out that, these models of care we have seen, they require funding. Take, for instance, the homes that were managed by religious organizations. When we went and asked them, how are they funding this agency? They said they go out to beg the public, and whatever they make from the begging, that's what they use to provide the needs of the older adults. And I said, no way, this is not sustainable. Because the public who give you money will one day run out of cash and support to give you. So what will you depend on? Again, we anticipate that there will be a challenge of there will be a massive unskilled caregivers providing low quality services to the older persons. Yes, because the individuals who are trained by these institutions, they are not skilled. They just gain training, but they don't have the skill. They don't have the training, the university training to be able to do this. And you will agree with me that services provided by an unskilled caregiver cannot be, cannot be equated with services provided by someone who is trained as a social worker. Then there is a hindrance and obstruction of an aspect of human rights, yes, of the older persons, because my research in 2019 and 2020 indicated that a significant proportion of the older adults in Nigeria and in the southeastern part of my country are interested to be placed in the homes, in the nursing homes, rather than being left alone to die in their homes. However, our policy in Nigeria, like I pointed out, negates that. It de-emphasized it, in fact, totally, that older adults shouldn't be cared at, in an institution. So we consider that an obstruction to human rights of these older persons. So what is the roadmap for a better practice? We said here, research, and researching social work profession and caregiving to older adults. Yes, we can do that by researching and communicating the findings from our research globally, communicating it to policymakers. There is an advocacy going on, and I'm sharing that with the help of my colleagues here. And what we are advocating for is a revision and a re-evaluation of our social welfare policy document, because it has been there since 1989. And not quite recently, in 2013, they sent me the document to review. And from 2013 till this moment, it is still in a draft form. So we said, no way. So we met and decided to write. So we've been writing, and we hope that very soon our voices will be heard. Then lastly, second to the last, we also advocate for promotion and inclusion of social work practice and the elderly among the core courses in social work education curriculum in Nigeria. It will help us to stimulate the interest of the young ones in our specialty, because we need younger ones to come up and join us in our advocacy. Then lastly, we talked about professionalization of social work. So when these things are done, we are hopeful we will practice better. Thank you for your audience. We welcome contributions.
Thank you very much, Ms. Patricia. And very serious concerns you have raised about status of social workers in geriatric care, and how the institutionalization of elderly care is kind of the care that is being given to the elderly, as you rightly mentioned, is mostly managed by unskilled caregivers providing low quality services. I think that's a matter of real concern. And also it's surprising that religious institutions or religious centers are taking care of the elderly care. I mean, they're kind of, they are the ones who own the institutions, are providing the care. It's very, as I can understand, a very unique problem, which needs, as you rightly put it, innovative ways of handling it. And I fully agree with your views on need for social workers to intervene at this juncture. Hopefully, your research will be able to, bring in the required change. And if we have time, definitely we will take questions from the viewers. I'm sure they are all having a lot of interesting questions for your presentation. Thank you very much once again. And now,
Dr. Nalini, Dr. Nalini, 1 minute. Dr. Nalini, 1 minute. Dr. James has come. I just want to, Dr. James, kindly, last speaker will join us. 15 minutes time, we'll get you in. Thank you. Can we wait for a few minutes? Thank you. Thanks.
Yeah, please.
Sorry for
no issues. Yeah, please go ahead.
Welcome, Dr. James. So,
Thanks.
Nice to have you with us. So now we move on to the last speaker for this session. That is Dr. Shanta Balaswamy. Dr. Shanta is a board president and client services chair, Asha Ray of Hope, Columbus, USA. She has long years of research and advocacy experience in the field of aging, apart from teaching courses on the same. Along with her academic work, she founded Asha, a Ray of Hope, a center to assist South Asian women facing domestic violence and abuse, and is providing the much needed support and legal aid to such women. And I heard a lot about you, Dr. Shanta. So I'm very happy to welcome you for today's session on social work advocacy for improving older adult care. So over to you, Dr. Shanta.
Thank you, Nalini. I appreciate the intro. But much of that's my volunteer work. I want to tell everybody that you spoke to my volunteer work beyond my faculty engagement in research and being on committees and task force on aging issues and publishing in pretty much in aging field rather than doing work in domestic violence. I do want to say that I will be speaking towards issues that are from lifespan perspective. So domestic violence is from a lifespan perspective. I did all my research in elder abuse and have made some policy and program recommendations. And now I am kind of moving towards the middle age or young adults who are victims of domestic violence. So there is a continuum of my interest in vulnerable population. So having said that, I want to greet everybody. Good day to everybody from different parts of this world. I appreciate your logging in to listen, and thanks to Dr. Gangadharan for the invite. So without, I will share my screen, I guess. Okay.
Yes, it is visible.
Yeah, it's visible. Is it visible to everybody? Okay, sounds great. So I want to kind of talk today about some background information of older adults. What's the role of social workers who can take opportunity if it presents itself to work in institutional settings? Because I think it's really important that, I don't know how to, let's say.
Just click on the slide.
Yeah, I just clicked on this. I apologize. So the objectives of this presentation are to not only identify what the role of the social workers will be, but also to present my own experience as a researcher who has studied residents and providers of old age home. I was corrected by Dr. Gangadharan recently that they have relabeled the old age homes as senior citizen homes. So pardon me if I continue to interchangeably use that terminology between senior citizens home and old age homes. They're one and the same. So why should we be concerned about senior citizen homes? We know that the population is aging and we can't depend on informal caregiving like families and relatives for especially frail and abundant elderly or those adults who are choosing to live in retirement homes or assisted living facilities and require healthcare and supportive services, as many of our previous presenters have indicated, regardless of the place they are living in or the continent they are living in. You also probably heard. So the other two things I will present is some challenges and also potential solutions, especially focusing on social work, gerontological social work, and using the terminology long-term care setting, because long-term settings includes retirement home, nursing homes, assisted living, and senior centers that we call them here. So as I was trying to say, that everybody has talked about the tsunami that we are facing of the overwhelming number of aging population. And in India itself, we are going to see an increase of 143 million older adults over the age of 60 in this year alone. And then we are also seeing that there's an overall population growth of by 56%, but then when you look at the population of 60 plus, it's going to be about 326%. I'm making these or sharing the slides is because I want to know what the role of the social workers are going to be in addressing the overwhelming number of older adults that we will be facing in various field placement settings. And are we really creating those field placements? That's my intent of sharing this. Also, to go quickly through this is we know that females are more likely to have a higher life expectancy than males. And also the life expectancy overall in this year is 69.96 years, or you can say 70 years, which is a tremendous gain for us in life expectancy terms, which is even also we have gained just between last year and this year. There is a 0.33% increase. Great, hurrah. And for the 80 plus population, there is not much difference, which is also heartwarming, where they live, whether they live in an urban area or rural area. But what is critical, I think, to understand regarding this is it will require, I think, because we know that majority of the population lives in rural area in India, and therefore it requires policy and programs in both areas. Currently, many of these old age homes or senior citizen homes are located in the urban areas. So moving forward on other aspects of why we should be interested as social workers is to understand the context of healthcare context, which is really important. So we know that one or more chronic illnesses or ailments are there among our older persons, and that will cause for having multiple healthcare condition causes greater frailty among older adults. And among 60 plus, most frequently occurring conditions, which coincides with my own data that I'm going to present in a few minutes, is things like arthritis, hypertension, diabetes, upper respiratory problems, and all types of heart disease, plus depression and loss of cognitive functioning are greater issues among the older adults, whether they live in the community or whether they live in residential care facilities. The proportion of people who live, elderly who live alone, also is interesting, because when you say 13.7% of 60 plus population in Tamil Nadu alone are living alone is a cause for concern, whereas in Jammu and Kashmir it's only 1.7% or close to 2%. And both this living alone status is going to increase, which means there has to be some safety net and support for older adults, those that are living alone. I'm not as cool as many of our other presenters to show all these cool diagrams, so I will stick to my basic presentation slides. So this I wanted to just share that I'm going to give some context, and I did a survey in 2014, and I'm now going to take a look at it to give you some reality test or orientation to what actually is happening. I know it is a little bit old data, but it still has so much relevance when I look at larger studies published by Lassie, the longitudinal study of elderly. So it has some relevance. So here's what I did. It was a cross-sectional design. I used both qualitative and quantitative methods to collect data. And my subjects were from Chennai and Bangalore. There were 2 sites, and I interviewed people in both paid and free old age homes. And in phase 1 of the study, I did 20 sites in Chennai and 20 sites in Bangalore for both paid and free old age homes. And then the second phase of my study, we had to do with doing both qualitative and quantitative interviews with residents, which was 181. believe me, as a statistician, I always wonder what's happening. So I'm going to only give you highlights of health area because I'm interested in speaking to the role of geriatric social workers. So here's a brief summary of it. So this basically shows you that ADLs and IADLs and ADLs. IADLs are like transportation, cleaning, washing, cooking, managing finances, etc. Are things that we do every day, and it is an indicator of our ability to improve our quality of life or measure of quality of life. The ADLs are feeding, dressing, bathing, walking, transferring, and taking medicine are considered as necessities for one to live alone on their own. And maybe this data will help explain why caregivers may choose their older adults to be in an alternate a setting other than their home. So the measures are all standardized measures. What was more interesting is when I asked the residents about their self-rated health, while most of them stated they were healthy, the group that we are most concerned are the fairly healthy and sick, which is kind of a good percentage. And also the number of days sick in the past 6 months is also a measure of one's ability to sustain themselves independent of caregivers or being dependent. So the measures of going from independent to dependency, that these scales actually help us make some assessments, and they are already a formal way of assessing the frailty level of an older adult. So what's really important is being able to afford medical care. Later on, I will say, looks like if you can afford medical care, which is in the paid homes, residents told me that they go to doctors when they are sick, they have attended, they have gotten surgeries, they have been able to access all kinds of services, healthcare services as and when needed. Whereas, the ones who were in the free old age homes, they were less likely to do so. So there is, again, I showed you some national data, and here's some data that I found from my own survey. So here again, the arthritis, hypertension, etc., the list of morbidity among older adults, which are listed on the left-hand side of the table, tells you. So what I want you to pay attention is to the hypertension being higher, hypertension and diabetes being higher in paid homes, whereas residents did not say, very low percent of them said that they had in the free homes, whereas they had more bronchial or upper respiratory problems and digestive or intestinal disorders. So the both groups have different focus of their health problems, and there has been not further research done to show why there is such a big difference. Also, the last thing that I wanted to share on this slide is the 3 or more health conditions. Amazingly, this is an important indicator of frailty. More than half of them, regardless of where they live, whether it's paid or free homes, they indicated having chronic illnesses. So moving further, this is the healthcare service utilization. As you go down, this data shows that the government-run organizations or free homes tend to use lower healthcare services compared to those who are in the private sector. And also looking at comparative data, hospital use and dentures were more frequently used by residents from paid homes than in free facilities, and almost half of the residents from both facilities use eyeglasses for vision. And we all know that those of us who are familiar with great programs that are there for vision care in India, including cataract surgeries to offering free glasses. So it's very prevalent. Testing is prevalent, and availability of glasses is also present. So this is really interesting. I was going to talk about the GDS scale, but I thank Patricia for showing the scale itself, the earlier presenter on the GDS scale. So in this particular data, you have to look at mild depression and moderate to severe depression. So it looks like both have mild to moderate depression. Residents were asked on the GDS scale to state, answer those questions, and it was amazing to hear that most of them was saying that this is the first time that anybody has ever asked them this question. So here's the response to why are they feeling sad, because I wanted to cross-test what I asked on the GDS scale to asking in a qualitative manner. It's important to do some cross-cultural validation of tools when doing research with older adults, depending on the population that you're administering. Tools that have been tested and validated for Western populations. So here are some reasons, like loss is number one thing that they're saying: loss of spouse, loss of finances, loss of friends. Those are all things that make them feel sad, they said, and also loneliness and no sense of belonging. So social workers have a lot of things that they can do to improve that in facilities or homes. Then unpredictability of the future. Growing older, civic engagement becomes a really critical point. If you don't engage them in activities, it's going to be difficult. And nobody wants to be dependent on others, which is really important, and feeling neglected or not having enough money. So this really tells us that as social workers, not only having empathy, but trying to find resources and connecting and linking services to older adults becomes very critical. There are some other factors that are associated with the GDS scale. It's age. Interesting is that the frisky, the 69 and below 69 frisky, and the fragile over 80 tend to have report moderate to severe depression. Significant relationship exists between age groups. Needs further study again to see why the frail people are not included in this group. Also, interestingly, we see that here men were less likely to indicate being diagnosed with a mental disorder, and age, marital status, and education had just nothing to do with having been diagnosed with mental disorder or mental illness. Doctors' visits and hospitals, hospital use was slightly higher among residents who reported having a diagnosis than those that didn't. Even though most reported having depression and feeling of isolation, no evidence to support that they were seeking help for this problem. I really wanted to share this with all of you. Ask the people, why are you here? Why is this alternate care suiting for them? What made them to be there? I just concised and got a theme going, and these are the major themes that I have responses that concur with other data from old age homes or senior citizen homes. Inability to provide care for somebody by the caregiver, which was mentioned by two other presenters. Therefore, they tend to put them in nursing homes or old age homes. And then, of course, there is stress in the family and interpersonal conflicts with adult children, spouses, or relatives. Abandonment, especially mostly for economic reasons, for poor, for low income or where poor economic situation can cause it. Social and cognitive impairment or mental disorders are also tend to facilitate admission into old age homes. Personal choice or absence of adult children, those two factors are also critical, and there are several studies out to support these choices. Personal choices includes those that have money and find retirement community attractive, which was stated in earlier few presentations. They like to stay independent and care for themselves, and that allows for private retirement communities. Whereas the absence of adult children tend to be more in private homes than in free homes, because the number of support system for financial support system is greater, and also we are finding that migration of children overseas tend to lead one to move to retirement community or paid assisted living facilities. Challenges. These are some of the challenges, and I was kind of pleasantly surprised what the challenges were in understaffed. In my study, I found that at least only 3 staffs for 100 some residents, whereas I was told earlier today in our just a passing conversation that the ratio is not so much the ratio, but the presence of social workers are there. But I'm assuming that the social workers are there, but there is no studies done. And I would encourage people who are working in the field to do some research and publish information or data on the presence of social workers in alternate facilities or in institutional care. My study also showed that both private and free homes had were dependent on paraprofessionals, and most of them were paying out of their pocket for their care. And also they had less access to healthcare providers, especially those living in free homes. And quite a bit of responsibility is on the residents to seek help for health issues, which I think is solvable, I think, by presence of a social worker. And also the limited formal, functional, and cognitive assessments, which are linked to actually providing a care plan for older adults. In my own context of my research, I did not see that happening, but I'm heartened to hear that there may be things that have evolved in this last 6 years where there is some effort being done to do assessments so that level of care can be decided for the resident where they come in. Also, there are few structured activities. I didn't see any planned structured activities for increasing mobility or increasing engagement, both for cognitive abilities, to improve cognitive abilities and physical abilities. There were a lot of spiritual contact, which allows them for emotional support. Also, as Patricia stated, low quality of services in the free homes than paid homes was observed. I'm going fast. So I wanted to kind of talk very quickly about how demographics can influence the role of social workers in healthcare and long-term care setting. When I talk about long-term care setting, it includes, as I said earlier on, the assisted living, home-based care, assisted living, and nursing homes or skilled nursing homes. But here I want to say that as we are having a tsunami of older adults, in the presence, it will increase the demand for social workers who have the geriatric knowledge, skills, and value. Also, a larger proportion of older adults can be seen in almost all of the settings, including primary care clinics, specialty care, inpatient hospitals, nursing home, besides their presence in the senior citizen homes. So what does that have to do? Social workers can provide psychosocial counseling for patients and caregivers, reference to appropriate financial, social, psychological services and community services, and they can be part of a multidisciplinary team. And in United States includes physician, nurses, occupational therapists, and other specialists would include them. So I wanted to give a brief definition of what constitutes gerontological social work. You have to read this in your own time, but I want to say it just means that social workers are the experts who can meet the biopsychosocial needs of the older adults. And they have to coordinate care for individuals with need for several services. And it's not just one time, but it's over a prolonged period of time. And that they have been recognized as experts in understanding what's normal and what's not normal in the aging process. That is by the NASW definition, which is critical for our understanding what I'm thinking about as opportunities. So I'm moving on to talking about, yeah.
Could we reserve this? I mean, I think we have also another speaker to go, and could you come?
Oh, you do? Did I do my 15 minutes?
Yes, ma'am.
Oh. Can I just like do the slides and show what's there and they can look at it? So, because it's self-explanatory, but is that okay? Give me 2 minutes.
Okay.
Okay. So here are the 2 slides that will show you what the opportunities are. These are the things that we do in United States, these tasks, these 4 different tasks. And here are some recommendations that I would like to share if we have time. And these are recommendations specific to the senior centers or old age homes, but I also want to share recommendations that are more designed for policy and related recommendations. Specifically, I want to have you look at the slide 28 and 29 and 30. These have to do with academic institutions, because we have a large number of academic institutions participating in this particular webinar, and I want to make sure that you get some information. So these are all self-explanatory. I'd like to see us involve some master's degree specialization in geriatric, and these are some ways that you can do. And there are some ideas of doing field placement in rotation and also infusing content in other areas of generalist practice. And partnering with community providers is very critical, I think. And I thank you for listening. This was
really sorry. I'm really sorry, Dr. Shanta Balaswamy, for a person who's such a big profile. As currently you are the professor with College of Social Work, Ohio State University, and your record of work with elder care. I'm really sorry I had to cut this short. I'm really sorry for this. And now it's all over to Dr. Gangadharan. Sir, I think you can take over from now, as you say, and then we come back.
Dr. I'm not going to take over. I'm just going to, as a courtesy demand, that I invite Dr. James to come. Nothing else. You are continuing to moderate and complete the show. I'm not going to get it.
Absolutely.
I think I must. The reason I'm very keen on Dr. James. Welcome, Dr. James. I think it's a pleasure having you with us. And we are sorry we have delayed you because we had originally said 7 o'clock. Sorry about this delay. But let me tell you that so many countries, 16 countries other than India, 17 countries have participated in the last 6 days. Extremely, very stimulating, very indulging. The reason I told, I requested Dr. Nalini to spare a minute for me to introduce. She's going to introduce you, but I just want to tell only 2 things. All of you need to know Dr. James has been very closely involved in a lot of research involving aging. I have been personally involved with him on 2 important areas. One was the building knowledge base on population aging in India, which was a big project that was done in 2012. Reports came in 2012. I happened to really be closely working with him, not on the research, but on the advocacy side. The second is that on behalf of UNFPA, we brought out a book on caring for the elderly. I happened to be one of those, contributors to this, and Dr. Giridhar have been the editors for that. The third thing is we also had a wonderful conference with the Minister for Social Justice in 2014 with a wonderful 2 days event that we conducted with the Government of India participation. I happened to work with him in addition to rest of the things. And I requested him to come at least spend 15-20 minutes, if not longer. Let me tell you, he's been one of the busiest person working with the Government of India and for the Ministry of Health. And the current situation, it's been very demanding. Originally, he said he will give the keynote address. He could not do it because of time. I'm very grateful to you, Dr. James, for accepting my request and being among us. There are 225 people listening to you today for next 25-30 minutes of time or 15 minutes of time. Dr. Nalini, take over. Welcome. You are muted. You are muted. You are muted.
Okay. I have been just allowed to unmute myself. So thank you very much for that, and welcome Dr. K.S. James. It's a privilege to introduce him. Dr. James is the director of International Institute for Population Studies, Mumbai. He possesses over 26 years of research and teaching experience in the field of population studies. Prior to joining IIPS, he was a professor of population studies at Jawaharlal Nehru University, New Delhi. He also served as professor and head of Population Research Center, Institute for Social and Economic Change, Bangalore. He holds a postdoctoral training from Harvard Center for Population and Development Studies, Harvard University, USA, and PhD from Jawaharlal Nehru University, New Delhi. He works extensively on demographic changes with focus on population and development and aging issues. Dr. James has published widely on demographic transition and demographic dividend in leading journals such as Science, Lancet Global Health, Social Science and Medicine, Population Studies, BMC Public Health, Aging International, Aging and Society, Journal of Aging and Health, Brown Journal of World Affairs, Maternal and Child Health Journal, Economic and Political Weekly, etc. He's been a visiting fellow in many prestigious institutes and universities, including Harvard University, USA London School of Economics, University of Southampton, University of Groningen, the Netherlands, and International Institute of Applied System Analysis, Austria. So over to you, Dr. James. We are all very eager to listen to you.
Thank you. Thank you for a very generous introduction first, Professor Nalini and Dr. Gangadharan. And thank you for inviting. It's a great pleasure to be amidst all of you. And particularly, I was listening to some of the presentations today. I was really intrigued by the quality of the presentations and also so much of learning for me as well, because this is sort of a new subject for me, the social work at the linkage with gerontology. But unfortunately, Professor Gangadharan has asked me to give a valedictory address based on the same theme. That is what I was really a bit skeptical how far I can live with his expectation. But at the same time, perhaps I thought, being a demographer, working in the area of aging for the last perhaps a decade or more, I thought I will still stick on to my strength and then speak on the issues relating to gerontology and the social work in terms of what a demographer can offer. That perhaps is going to be my talk today. Let me just share a few of my slides, which I hope it is now visible, because I know the time constraints, so I would also be perhaps a bit fast, as well as maybe skip some of the data part, which I thought may not be important for this audience. So I would generally go at the macro level. I don't really get into the details of any of my issues, which I am going to discuss today, but primarily look at the macro level in the country, what is really happening and what is that we really need to look at. I was just curious yesterday, since Dr. Gangadharan asked me or given me this title, because it is not my title, what is Dr. Gangadharan's title. And he asked me, can you, James, please speak on what is the linkages between social work and gerontology. So it has been a challenging. So I thought perhaps it is good for me to really refresh on what is social work first. So it is, I would rather take, not that I'm going to deal with social work, but I would like to take two important aspects of social work and see how actually it can be linked with gerontology as well as from a demographic perspective. That is what I would rather like to do. The first, definitely, as all of you know, it is the, let me see, how do I, okay. It's a discipline that involves application of social theories to have a better understanding of society and people. So because, because many of these are students who are really studying in MSW or dealing with social work as a discipline. So it is also important to understand what is the other discipline offers in terms of theories to really understand gerontology much better. I think that's very, very important. And I'm not going to offer from any other discipline, but I will limit myself to the demographic discipline. And it's also important because as a profession, it tries to improve the well-being of the individuals and families and communities. So social work also involves a sort of a community service. So naturally, we really need to see if there needs to be a service, what is the empirical evidence for that? Because as a demographer, we always look for evidence because we are very good in really looking at evidences in terms of data, in terms of the critical understanding of the percentages and rates and ratios. So I would thought, although I am not going to touch upon much of the data today, but I thought it is important to say that what is important if in case we want a profession to improve well-being of the individual, well-being of the families, well-being of the communities, what is important, what does the data suggest? So I would limit my presentation on these two aspects today. So let me come to the first aspect, which is actually what is the demographic community tells you in terms of the theoretical aspects, why actually the population aging is important. My feeling is that this is important because of a couple of reasons. One is we always ask a question, what are the implications of population aging drawn from other disciplines? I think, this perspective from demography, what does it really conveys? So why it is population aging is so important in India, especially for a community of social workers, is because the nature of our population aging is substantially different from what is we draw from other experience of other countries. So we really have, perhaps India is going to give a newer dimensions of population aging compared to other countries of the world. What is that newer dimensions? Because any countries of the world, if you can really look at how population aging has happened, it is primarily because there is a socioeconomic improvement, there has been a demographic changes. Naturally, there is a shift in the age structure of the population, which led to higher proportion of population at the age group of 60 or plus or 65 plus, whichever you do computations. But in the case of India, it has been slightly different because our demographic transition theory, which has been from the experience of large number of countries, which unequivocally told that you cannot have a transition unless there is a socioeconomic improvement in the life, unless there is an income improvement, unless there is educational improvement. All these are sort of mandatory to become a really good, to have a population transition or to have an aging society. But what happened in India? None of these are true. If you really look at the experience of different states of different parts of the country, I think our demographic transition but never been preceded by substantial socioeconomic changes, substantial economic changes. Neither on the other hand, actually bulk of the females or the couples who adopted family planning in this country was from the poor sections of the population, were illiterate. So the entire transition which has been experienced in the country is substantially different. So you would get an age profile or you would get a characteristics of the elderly considerably different from the other parts of the country. Institutional development, you can say lack of institutional development, it has been talked about by many of the previous authors or previous speakers. We always will, because we didn't have any institutional development for a population aging. But Western countries has experienced all those things over a course of large number of years, almost a century. We are experiencing a demographic changes within a very short span of maybe less than 30 to 40 years. So that is why, I don't know if you're Indian audience, all of you know, there is always a debate on demographic dividend in this country, because everyone say we don't have dividend. Why it is so? Because we adopted a system, we adopted a policy framework where we wanted illiterate, poor sections of the population to adopt small family norm. Now they are in the adult age group. Now we are complaining that they are unskilled, they are poor, they are illiterate. What can we do with them? But it's a conscious policy decision. One has to understand it. Good or bad is something we can really discuss later, but that is what is going to happen. Give just an example. If you really look at illiterate fertility in this country, many of the states have achieved replacement level fertility being an illiterate. So it gives an example really how really the demographic changes happened in this country. I'm also giving an example how we are going to have this population aging in the future. Look at up to 2020. It has been very minimal. If you look at 65 plus population, it was very minimal, only for 5.1% of the population. But we are going to have a very rapid changes from henceforth. So 20 to 50 or 20 to 60 is going to be very, very important for this country. We have an exponential growth of aging population. And you can see even 65 plus population will be going to be more than 100 million of in the this decade which we are living, and it is going to go very, very fast. So this is what is it is called what is called the pace of aging in this country, because for the Japan or France or Sweden, it took almost 120 years to become from 6% to 12% or double the proportion of elderly. So how much time we are going to take is hardly 15 years. So that is the proportion or the pace of change which we are going to talk. That is what we are going to experience. So naturally, we need to be also careful. So what is that demographers can offer in terms of the theoretical aspects? After that, I will come to some of the empirical aspects. Now, if you really look at the transition, the social demographers really classify our entire generations into mainly 3 groups. I think all of you, if you really experience what is really happening now, we can really understand this. We know there has been, if I look at my generation, which have, my old generation, many of you may not be my generations, which are much younger because we are students, many of you. But my generations, my parents, if I ask, they have large number of children. Some of them get educated, some of them did not get educated. I think they were child neutral. They were never bothered. It was a high fertility situation. They tried level best to educate us, to make our life as comfortable as possible, but all of them could not succeed. So it is called a child neutral era, which was really happened in India and in the past, but may not be at right now. But the transition process is called child king era, which is called when the fertility transition happens. This is actually a French philosopher has told this term. He said, what is the change happening in the society? The change happening in the society is that child become the king of the society, because every attention is on the children. You just imagine if suppose 2 parents now meet, what will be their talk? They will definitely talk what your child is doing, or my child is in this college, what is your child is doing? Because your entire attention of the society is on children. So your talk on is on children, your investment is on children. Parents don't bother even to invest whatever is the amount on children now. That is what actually the current society we live in. Because children become the king of the era. Children become the attention of the society. Everything is invested on them. Every effort is on them. But we are going to change. That is what the next level of transition, which has happened in many Western countries. From child king era, there can be another situation called a child trifling era, which is called an individualistic era, where actually the parents try to calculate now. Parents like to think whether we need children or not. Having children or not having children become a debatable issue between husband and wife, and children is not given that much priority in the society as much as which we see the child king era. Because fortunately in India, we say we are living now in a child king era. We don't really know what is really happening in the other society. But this is where actually we would also see a very rapid population aging, and where there is a large extent of migration, and there are a lot of changes which happens in the society, which really directly impact the population aging, which directly impacts the elderly in this world. So if we are moving from a child king era to child trifling era, that is where we need to be worried. I'm afraid whether the next coming 2 decades or 3 decades in this country, when we have a rapid population aging, are we also going to move that era? We don't know, because our society, we still think that our society is very strong, our community is strong, our family is still strong. We really don't know whether we will have the same experience of Western countries, but we need to be careful about it. So this is where actually as social workers, everyone needs to be to invest time and invest actually both in terms of theory, in terms of the ideas, in terms of what will be the future society we are going to live in. So let me stop at the on theoretical part, maybe take another 5 minutes on the empirical parts, and then stop my presentations.
Dr. James, don't cut. Please continue. You're just making it interesting. Don't cut. We just want to listen to you, please. Thank you.
Okay, sure. Yeah.
But sorry, Dr.
I was only looking at the watch because it's already 7:45.
No, I'm seeing you looking at the watch. Please, people who are going to leave, nobody's going to leave you because you're making it very interesting.
Okay, thank you. Okay, let me come back to then the question of vulnerability. Because as I told you, the demographer's work has always been in the question of measuring it. What is a major vulnerability? If you think that the one question we have to ask is whether population aging is a vulnerable period. Is it a vulnerable period? What is the extent of vulnerability? What is the support we need? That is what actually a social work profession can intervene. That is very, very important for us. So naturally, we need to really see the areas of vulnerability. So I just have made a broad pre-classification. I think that is very broad. We cannot really say this is encompassing, all encompassing, but we can say, okay, it really covers 3 major aspects. One is the income security. Elderly definitely want to live with that basic income, as I told you, because we are in a transition where most of the illiterate, poor, unskilled, etc. will be in the population aging for the next 30 to 40 years, because all those people who are coming into the level, so the population age pyramid in right now or even next 30 years have been educated some 60 or 40 years back, which they did not get adequate education at that time. They did not have adequate saving at that time. So naturally, we cannot expect them to be richer or to take care of themselves. So that is one important aspect. And the second aspect everyone is discussing is what is a household composition, whether we are going to change living arrangement pattern, whether we will have less people to take care of the elderly, because family has been the cornerstone of the care in this country. Are we going to change? If it is going to change, naturally we need to address that very seriously. What is the evidence for it? More important is the evidence for it. Although I'm saying there are sporadic kind of a newspaper writing, journalistic writing on much of it on the urban corners, where actually some it is neglected, some it is the roads and all those things. But that is not a macro picture. What is a macro picture on this? That is what we are going to look at. Thirdly, I think the most important one everyone talks about is the health vulnerabilities, naturally, because being older has several health issues. So naturally, that is what important for us to really discuss. So let us really look at the empirical evidence on it and then see where actually a social worker needs to intervene. Let me come back to the economic aspects. You know, what is a major change in the economic aspect? That is what we really look at. If you really say that, you know, most of the literature tells you the rapid population aging with less economic contribution from elderly will have direct bearing on their well-being, that all of us know. And we also aware that social security measures are nearly negligible in this country. And we also aware that the economic contributions are perhaps will be dwindling in the older ages. So naturally, it is possible that family has to support them or someone else has to support them. It can be family, it can be government, it can be community. So there should be some support to them. But what has been the evidence? If you really look at the past evidence, which has been found that the households with an elderly living has been economically better off than a household with a non-elderly. It was quite surprising. In India, it was been very, very surprising. We always thought the other way. We always thought that the elderly households are worse off because the people have to take care of them there because they are poor. But in the past, it was not the evidence because there are a large number of NSSO surveys. We had even our Professor Gangadhan, Dr. Gangadhan has mentioned about our BKPI survey. All these surveys invariably showed, in case you have an elderly with you, you are economically better off. How that can happen? It can only happen because they have been economically contributing. if you know, there has been a very big study which has been conducted all over the world, which is called National Transfer Account. It was actually the purpose of that study, which has been done by some very famous scholars like Ronald Lee and the Andrew Mason, etc., from the University of California. They looked at, and India has been found an exception for them, where they found that there have been substantial amount of transfer from elderly to young generations. So that has been quite a surprise for them. So that way, we always found that elderly has been contributing because they have been working. They didn't stop working at age 60 because there's no retirement age in this country. Many of 90% of the people are in the informal sector. So naturally, they have been working and they have been contributing. So there has been work-related vulnerability because although 57% of the illiterate continues to work in India at the older ages, but if you really ask the question to them, are you interested in working, or you have been working by choice or working because of compulsion? Many of them, almost 70% of them told we are working because of compulsion, not by choice. So although we always say that elderly should be encouraged to work, but in Indian case, it is slightly different. And if you really see even now, almost current workers constitute almost 36%. And we always say there is problem with work and at the same time. But what is the newer evidence? If you really look at the LASI data, longitudinal aging study, which has been published by our institute a few months back, the situation is slightly altering. Because as I told you, all these studies until now has been telling that if you have an elderly household, you are better off. Now, if you really see a per capita expenditure or per capita income, in both these cases, non-elderly households are better off. So things are rapidly changing. What is this change happens? This change happens because of two reasons. One is that you have an expanded life expectancy now. Earlier, most of you elderly don't live that much longer. So at the 60s and even early 70s, you were able to contribute. But when your life expectancy even expands towards 80s and 90s, their contribution comes down. So that is really happening in the society currently. So that way, the economic contribution of elderly compared to the past may not be as high as that. And secondly, this also reflects there's a proportion of elderly is also increasing. Because when you have a household, when you have only one elderly, it is different when you have 2 or 3 elderlies. Because the proportion, because of the rapid change in the age structure of the population, because the proportion of younger people are coming down drastically in this country. Even in 2011 census told that you have 0 to 6 proportion of the population is declining or negative in growth. So naturally, you also see the proportion of elderly going up. That really is changing the dimensions or you can say the structure of the transfers between generations. That is a point we need to be taken care of or taken note of, because earlier elderly was an asset. Now slowly and slowly, because of the increasing expanding life expectancy at the macro level, it can become a burden. So once it becomes burden, so naturally you would not see the family integration which was happening in the past. Family was very strong. Perhaps when the economic contribution comes down, it also many often we found that, especially at least among the poor sections of the population, we may also see the parents left alone or left behind. So all these things can really happen when these kinds of macro changes happens. So this is on the pension system, which I would not get into much. The working things, as I told you. So what is that we need to conclude on that? So I would say that we are in a period, sort of a transition period. So that is what I told you, 2020, which I told you in the initial, my graph also. We are going to have a very rapid aging now from 20s onwards compared to the past. We also will have an increased life expectancy because our life expectancy is going up dramatically from, we can say, a couple of decades back. It was early 50s and now it is almost touching 70s, and maybe we will be closing to 80s in the coming years. And life expectancy of 60 plus is maybe another 30 years. So naturally, they will also going to live more if you're able to survive up to 60. So all these things will really rapidly change our age structure, our transfer system, and elderly can become more of a burden compared to the past, where elderly has been contributing substantially to the family. So if that happens, naturally, we also need to rethink our strategies, whether family can become the sole caretakers of the elderly in the future. I will leave it to the social workers to think more about it. And I will come back to the second vulnerability aspect, the living arrangement aspect. Now, the living arrangement aspect is always been talked about very seriously. And many people say, okay, there are substantial changes, living arrangement and all those things. But the question is that living arrangement changes alone is not the issue. The issue is when you have a structural changes. What does it mean by structural changes? The structural changes means it is like in a Western context, parents live with children is unimaginable there. Parents has to live alone and children live differently. So it is a change in the society which happens that, almost the elderly are supposed to take care of themselves. Is it happening in India? Our studies, we can say, shows that there is a very thin evidence on that. What is really happening in India? We see large number of parents live alone or the elderly live alone, but that is primarily because the elderly the children are migrants because of better education or better employment opportunities or better other options. So parents are happy about it. Most of the parents, if you really go and ask a question, are you happy about your children migrant? They say, I will be happy because they take credit out of it because my child is working in Bangalore in this a particular industry, or my child is working in Delhi because in this, parents are happy about it. So that doesn't also mean that the children are not supporting the parents. They're always there to help them. They are able to help them financially. They also help them physically as much as possible. Whenever their parents have an issue, they travel back and take care of them. So all these kinds of linkages exist in this country until now. But the question is, will it change? And if it changes, whether actually we will have a system where we inherit from the Western context or other contexts which we have currently experienced, where actually living arrangement become a structural changes rather than because of the necessity changes, like what is happening in India. If you really look at living arrangement pattern, the co-residing without children has substantially gone up, because in 2015-16 it was only some 17%. Lassie tells you something of 26%. So it means that there are a lot of migration happening. The adult migration is happening, which makes it parents to live alone. But in different states we see different patterns. In Tamil Nadu we see one pattern, but in Kerala we see different patterns. So we cannot also make much out of it. But what is it all we can conclude? I'm not the one who really thinks that there is going to be a very substantial changes in the living arrangement pattern, like in the case of Western countries. But I'm really skeptical, primarily because of the first slide which I showed you on the family income part. Because as I told you, when income contribution, economic contribution of the parents declines substantially, it is at least among the poor sections of the population, how actually the living arrangement pattern is going to play out in the future. It is something to really have to guess. It is completely a guesswork at this point in time. So we are not able to give a definite answer. But at the same time, we always feel that our family is still strong and may have some impact on the living arrangement. But what is more worrying about living arrangement is the living arrangement between men, the difference between men and women. Because if we really look at the data, where is actually living alone is highest? It's among the female living alone. The men is always less than 5% or around 5%, but female comes to almost 10% or 12% or beyond that. It means that living alone is a function of widowhood. Living alone is a function of the spousal difference in the age at marriage. So this is and also we can say higher life expectancy among women. So these are the factors, actually sort of cultural factors we really need to address if we really also want to make sure that the widowhood percentage also declines in this country. Because of widowhood, I think many females are living alone, and all of you know widowhood has its own vulnerability, and that also leads to many other issues and also the problems. So let me come back to the last one, which is health, which all of you know, increasing life expectancy, but at the same time, burden of disease is substantial. And all estimates show that minimum 50% of the elderly lives at least with one chronic disease in this country. This is the survey which we have conducted. UNFPA survey shows. The Lassie also gives that evidence. Lassie told 52.1% lives at least one chronic disease. And lastly, another evidence was that around 24% of the elderly has at least one issues of activities of daily living. What does it mean? If family is not taking, suppose you assume that family is not taking care of them, what does it implies? That we might need, there will be something around 25 million people in this country. If there are 100 million elderly, 65 plus, if you assume, there are 25 million elderly in this country needing some care. So if elder care is given by institutions, you need something around at least 20 million people, institutional people, to give support to such kind of an elderly, which is huge in demand. So I think this is another area where actually social workers has to really come in, where the elder care is needed. I think there are very classic examples from different parts of the country. I think I still remember with Gangadharan working on the palliative care in Kerala models and all other things. There is a fascinating experience where actually there are innovative, better way of dealing with elder care. So I think we really need to learn lessons and also provide support either to the government or to NGOs or to communities. This is what another major issue. So I don't think that I need to get into this data part. So let me finally conclude on 2 or 3 points. So I talked to you about the nature of demographic transition, which is significantly different in this country, and India, as I told you, an exception, and South Asia perhaps is exception, but India is a sort of a leader in South Asia. So naturally, we need to really see, we really don't have any experience to suggest how our demographic transition will play out for the elderly, because we need to really have guesswork. We also need to have hunches, and we need to really see what would be our family pattern, what will be our society in the future. That is itself is a bigger dimension, a theoretical dimension, actually, any social work student should be interested in. And lack of institutional setup, which I have already mentioned, because we never anticipated it. We were all concerned with overpopulation, we were concerned with controlling population, but through that process, we also created an aging society, which has a significantly different characteristics than what experienced in other countries. I also mentioned about areas of vulnerability, 3 broad areas. You have to unpack it, because I didn't unpack it. There are different dimensions in each of these areas, but I just gave you a macro picture what is. So I believe social workers at least has an important role in both these aspects, the nature of the demographic transition, the theoretical aspects, and also to find out the areas of vulnerability and really to give a guidance and also a directions to the social work. And I'm sure the large amount of work social workers are doing will definitely benefit the society as well as the country as such, because as I mentioned, we are really starting, 2020 will be sort of a turning point for us in terms of the rapidity of pace of demographic changes, the pace of aging, as well as the pace of changes in the structural, in terms of income, in terms of other contribution, living arrangement, all those things changes we will see in the coming a few decades. Thank you so much for invitation. I know it has been heavily loaded in the sense that it's very macro in nature, but I hope it would have been useful to those who are attending, especially the students. Thank you for the invitation once again. I think Professor Gangadharan, you are muted, I think.
Asking her to unmute. Dr. Nalini, unmute. You're not, Prabhakar, can you just check? No, you have to come back. You have to unmute. None of us can help you. Anyway, let me do your work now. Let me complete, because everybody is getting restless.
Yeah, got it. Yeah, now it is unmuted.
Wonderful.
Thank you for the wonderful session. I mean, it's really a totally different perception and paradigm shift, the way social workers should approach to handle the problem of the growing elderly population. And I mean, such valid points, especially with regard linking the child neutral era to the child trifling era. I mean, that's a very, I think we really have to put minds and hearts together to think in those angles and find a probable solution so that we can face this expanding life expectancy without any fear, because that's very important. We have to approach it in a positive manner. And thank you very much, sir. I mean, 234 participants still. So that itself shows I didn't miss even a single word of what you said. I think we should have had more of your discussion. And thank you very much. And thank you very much to all the speakers. Running through all these what we heard today, three common things that I can draw out of all the discussions. One, health is a very important factor for the elderly, because we have to plan and stay and manage their health, because one day all of us are going to hit the age. And the other problem across all these nations, what I find is the health concerns, as you said, more than 25 million people, or more than half the population has some else, non-communicable diseases. That is what Mr. Arali from Uganda also had said, that he had said that one or two NCDs are there in their aging population also. So health is a concern. And the other thing is loneliness or abandonment or isolation. This is another common thread across the globe. And of course, the increasing aging population because of the life expectancy. So I think, and this has to be tackled by social workers. So I once again take this opportunity to thank each and every one of you, especially the speakers for the day. I would like to, once again repeat their names with the permission of Dr. Gangadhar. I know the time is up, but still, I would like to thank Dr. Sangeeta Singh from Malaysia, Mr. Namara Arthur Arali from Uganda, Mr. Albert Blimex from Netherlands, Ms. Patricia from Nigeria, Dr. Shanta Balaswamy from Ohio State University, and Dr. James, who gave the grand finale, and to all the other collaborating universities, institutions of social work and other institutions, and all the faculty members, professors, and last but not the least, to all the participants who made this a successful event. If not for you, this 6-day program webinar would have been not successful at all. And we are really sorry we could not take your questions. But I am again going back to the the grand young man of this webinar, Dr. Gangadhar Reddy. I won't say old, I say grand young man, who will, I'm sure, come back with a strategy to handle all these questions which are left unanswered. But I'm sure we're all taking away a lot of valid points to think and mull and work on. And I really salute all the experts who are working in the field of gerontology. Hats off to your patience in handling a very sensitive issue, and all the other senior citizens who are there to have taken interest to come and attend this webinar. So from our side, I sign off. I thank Dr. Gangadhar for giving me this opportunity. I really enjoyed doing every bit of it. Thank you, everyone. Thank you, all my fellow colleagues and my fraternity. Thank you.
Okay, now it's final, which, Dr. James, absolutely, you took us all by, she said, finale. It's actually by storm. You took us by storm. Let me tell you, you gave a new perspective. The social work profession, let me tell you, barring UK, USA, and few countries, social work is not recognized as much as far as a geriatric care is concerned. But fortunately, in India, the government of India has recognized this profession, at least for the sake of old age homes run by them, funded by them. We want to take advantage of this because there is going to be, I think you are given a huge picture. The numbers are going to be one of the biggest things that you are talking about, and just not the numbers, the implications in terms of growing older, longevity, the implications. I think it is just not going to be the social workers alone who can do much more than that. Thanks a lot. And let me tell you, as usual, I'll trouble you once in a way for this kind of important talks, not otherwise coming and troubling you, respecting your things. And I also take a responsibility at this point of time to particularly thank, I'm trying to look at the family, the members of the team that put us together. I'm looking at Dr. Leena from the Manipal University, whether she's going to come in and appear on the picture, because I want to take a picture of all of you. And, it's a just nice memory I want to have. Dr. Chanavir has come. Personally, I must thank, let me tell you, Albert. Albert has been holiday. I can tell you he was getting angry that I wrote him so many times, but I said he must be there with us. And Freak was also there. I said, you need to be there. I will wait. Don't worry. You come and talk. And it was the last day. Let me tell you, I must personally express my gratitude to you. Though you didn't have time to talk, let me tell you, Dr. Albert, it's a beautiful session that you had with us. Wonderful numbers. And on the last day, that too after half an hour after the session is over, you still have 230 people hanging on at 8:15. It's a fabulous thing for us. Thanks for making it. Dr. Shanta, that I had, thanks to Dr. Raja Samuel, who connected us in the last 1 month time, though I've been meeting her. I'm very happy to see a lot of pictures coming in. Please, Kim, please keep coming. We would like to take as many pictures as possible. All of you appear on the video. We would love to see you. And I would like to thank, I don't want to keep talking about every one of you, but let me tell you, as Dr. Nalini beautifully said, this program would not have been success, but for all the pictures that I see in the video. Every one of them I want to put it. Let me tell you, I never knew this event of 6 days will be almost a grand success the way it has been. Thanks to every one of you. I've been getting excellent feedback from people, and I'm also putting all the feedback on the Facebook, so people know transparently what has been happening, though we would like to do that. All of you have your feedback. You also have access to the YouTube. All of you can go through this with a lot of happiness, because I think transparency is learning. I think Dr. James, the way he spoke, or Albert, the way he spoke about the Netherlands, and Dr. Shanta Balasamy coming and visiting India and talking about aging old age homes in India, or Patricia, who's going to be a PhD soon, would like to enjoy what she learned. I think today a lot of points you would have picked up for a PhD from, at least from not anybody else, at least what Dr. James mentioned. And I'm sure, Arthur from, Uganda is another person who has been very keen on, getting involved in it. And I just don't want to miss all of you. Let me tell you, it's been a wonderful experience for me personally. I have organized, Dr. James has also been part of me in organizing major events. We had 300, 400 people coming to Hyderabad on a global conference. But let me tell you, having this conference on a virtual forum is the last thing that I expected response. Thanks a lot. I don't want to take longer than what it is. I request all of you to take some pictures so that if I miss anybody, you can change. My dear Jagannathan, my classmate from Guru Nanak College, is also here to listen. I'm very happy to have. I'm also happy to see Mr. Raina from, Uttarakhand here. And Gumadi Prasanti has been there continuously. I've been seeing her. She has been attending the program. And there are many others. Christy, I've been seeing Christy. I think Christy's face also appeared on the Facebook today. I put her picture. And Margaret, nice to see Prince. Nice to see all of you coming in. And I wish more of you come in. Thanks a lot once again. I think Dr. James, particularly thanks to you for, I know that you must be very busy. It's already 8:15. Go home before your wife tells no food for you. Thank you. Thank you then. Thanks. Thanks a lot.
Thank you. Thank you.
Thank you.
Excellent. God bless you.
Now you can talk whatever you want. All of you can talk whatever you want to talk. The mic is on. All of you unmute and talk.
Yes. Thank you.
Thank you. It's nice.
Thank you, Doctor. Thank you, Dr. Gangadharan. It was such a beautiful event, 6 days program. Very well done. Thank you.
Thank you.
Yeah, and it was not
Thank you.
It is a success. You mentioned almost success. No, it's a success, but a grand success. Okay, so signing off. I need to go back home. I'm in the office. So thank you, everyone. Good night.
Thank you, madam.
Nice.
Thank you. You did a great job, Dr. Nalini, today.
Yeah.
Thank you so much.
Thank you.
Thank you, sir.
Thank you. Pleasure.
Bye.
Now it's photograph time for me.
Thank you, sir.
Thank you. Pleasure having all of you.
Bye.
Pleasure.
Bye, sir. Thank you.
And hope we'll have a bigger event in the next 6 months' time.
Sure, sir. Sure.
Fabulous, Ganga, once again.
Time. Please invite me again.
Congratulations to the entire team.
Yes.
Yes.
Prabhakar, Prabhakar, can you come? Prabhakar, can you come on the picture? Let me tell you, one person I really need to thank is Prabhakar, who was behind the scene. I'm telling you, Prabhakar's mother is sick. In the last 4 or 5 days, she had a paralytic stroke. But let me tell you, he has been working. He went for 3 days ago. The mother is not even able to thank. He's a person whom I like to thank. Prabhakar, show me your picture. Let me show your picture. Spotlight. Okay. Hey, you are not seeing your dark. Come properly. So Prabhakar has been a, what is called the technical man for me in getting this program organized, sending messages along with Sweta is here. If Shweta is there, I would be very happy to have her too. And Vijay Lakshmi is there. I'd be very happy to have her too. So that's where it is. I think they have been a big team for us. Thanks a lot once again.
Thank you.
Dr.
Thank you.
Mushwinder Pal has been coming. Dr. Popley has been coming every day. She has been giving you a lot of encouragement and support. It's nice to have her picture today. Nice to have her picture today. Very nice that you came. And Mr. Captain Singaraja must be 80 plus. He has also been attending the program regularly. Mr. Ramakrishna from Visakhapatnam has been attending regularly. And these are all the people I can just recollect. Yeah, maybe more people are there.
Thank you very much, sir.
Charu Old Age Home from Hachennai, good.
Ramakrishna from Visakhapatnam, thank you very much.
Namakkal, very nice. Nisha Mathur, very nice to have you with us. Dr. Sigamani, we should give you a separate session for you.
Sir,
Dr. Raja, I hope Dr. Samuel, very nice of you to come to the last day.
Oh,
despite all your
it was
admission.
great. Yeah, it was absolutely fabulous, I think.
It's been a wonderful show. Yeah, I enjoyed it.
Sir, you got an excellent team.
Congratulations.
Thank you.
Shagin.
Oh, yeah, Dr. Shagin, yes, we have been corresponding in the last few days.
Sir, today's feedback form.
Thank you so much. Thank you so much.
Thank you, sir. Thank you. Thank you.
Dr. Mangaleshwaran, thank you. We did a lot of programs last year. This year we have done
thank you. Thank you, sir. That's a great job, sir. Yeah.
Different kind of program.
Thank you.
Jagan,
Thank you all.
You missed 4 or 5 days, but you enjoyed it today.
Sir, today's feedback form.
Magajan. Thank you, Magajan.
Thank you, sir. Thank you. Good night.
Good night. Good night.
Sir,
Prabhakar, is all
feedback
going?
form.
All feedback is going?
Good night.
Okay, I will send you the feedback about all of you so that you know how people are measuring you. It's nice to have feedback from people who participated. So with this, I will also close. Thanks a lot. I've been extremely busy with other work. I think from tomorrow I'll concentrate on something different.
We haven't got the feedback link.
Prabhakar. No, feedback group would have come long ago, ma. Prabhakar, put it once again.
No, there is no feedback link.
Don't worry,
No, there was no feedback form at all today.
Today, Prabhakar?
Yeah, not at all.
Times I'm sharing it one more time.
Yeah, it's come, ma.
No, it hasn't. We have been writing many hundreds of messages.
Oh, sorry. Lucky that you asked me before it is too late. Oh, a lot of questions have come on feedback. Yes, I'm seeing it. Certificate, it will take a few more days because we have to coordinate with all the 9 universities and get their signatures and then do it. It will take a few days. It's not issued by the Heritage Foundation alone. I request all the university representative to sign those university to affix the signature so that it has more validity for you when you are seeking jobs and any kind of university recognition. Now I think the feedback is there now.
Yes, sir. I just shared one more time.
And so we are sorry about this. We didn't know that it was not coming to you.
No, I shared so many times, sir.
Revati is asking for your number. Prabhakar, I do not get any mail from you. Even there is no any contact number in the flyer. Now, we don't normally give the contact number in the flyer because we don't know how to handle so many people. So therefore, we are maintaining only email contact. Mr. Cabra.
Yes,
Mr. Cabra, nice to have you. Mr. Cabra, who celebrated his 90th birthday, is closed and walking out. Okay.
Hello.
Dr. Lizzie, very nice to have you from the institute. I really look forward to working with your institute next time.
In fact, we are also having some discussion, sir, for having some program, organizing some program.
Yeah.
Thank you so much. Thank you so much.
I'll be in touch with you. I've written to you also. We'll be in touch.
Yes, I got that message, and in fact, we will have a kind of discussion, and we'll come back to you, sir.
We will do. Thanks.
Yeah.
Thanks once again.
Yeah.
बघायला पाहिजे होती काळी भंगार बाई होती बाई